So we are going to talk about lupus nephritis today, which is a huge topic. So my fear is that we'll probably have to spread it over 2 sessions, which is fine. We will just do it like the way we did for FSGS. The way we are going to divide the talks is today we'll have a very brief introduction to the pathology of the disease. Dr. Latif and Professor Mubarak are going to help us dissect through some of the nuances of that. And then we will start going through some very interesting cases, one from Pakistan, one from the US, and then several other small snippets which make us which will help us walk through the various shades and colors of lupus nephritis. So I'm going to start sharing my screen. Okay, so you should be able to see my title slide. Can you see my title slide, guys?
Yes.
Very good. Okay, so lupus nephritis is a treacherous disease, and it is a disease that wears many coats. So as nephrologists, as pathologists, and as rheumatologists, we have to be very careful in diagnosing this disorder and then thinking about the most rational therapy for some of these patients. And that's where the art of medicine comes in. Not all lupus is the same. And the finessing of what treatment to pick for what patient in what stage is what distinguishes a good from a weak clinician. So the disease starts sometimes decades before they come to see us in clinic. The underlying problems are genetic, and there's some environmental triggers, and we'll talk about these very briefly, which then lead to activation of the innate system and lead to an innate and adaptive system crosstalk. Immune complexes form as a result because the adaptive immune system then leads to B-cell activation and antibody generation. And then after a variable period of time, clinical disease starts manifesting. There are pathways that are aberrantly amplified, which kind of leads to organ system disease and also leads to progressive difficulty in treating them with immunosuppressive therapy, and eventually irreversible tissue damage can happen. It does happen, and we deal with this all the time. So what are these autoantigens that actually lead to lupus? So there's a very clear sequence of events here. There is an exposure to certain antigen, there is aberrant response to them, and then that aberrant response leads to generation of autoimmune response, which causes manifestation of the disease. And mostly what these are is remnants, intracellular and intranuclear remnants, which come out of dying cells. So cells are supposed to undergo apoptosis. They can then be opsonized by phagocytes. But in lupus, what happens is that there are certain genetic disorders and genetic defects that lead to delay in removal of these fragments from the circulation. And these actually, the immune system actually sees them as viruses. So it responds against them as if they were viral nuclear particles. Also, this is a complicated schema on the right-hand panel here, but what we are looking at is a neutrophil. When neutrophils go after bacteria, they sometimes release these nets, neutrophil extracellular traps. And these are large amounts of nuclear DNA. These are kind of spit out into the extracellular space. They're essentially like spidey webs, and they help immobilize and opsonize invading microbes. So they are a defense mechanism. In some patients with SLE, the degradation of these nets is impaired. There are some problems with DNase 1 inhibitors, or there's some antibodies to nets that develop. And that then leads to stimulation of plasmacytoid dendritic cell, which is a key player in the pathogenesis of lupus on the innate side. The plasmacytoid DNA cell actually sees these nets, which are processed through the toll-like receptor 9 pathway and trafficked in through MyD88 and TRAC. And then that leads to a multiplicity of reactions by the plasmacytoid dendritic cell, including release of high amounts of type 1 interferon, which kind of leads to further inflammatory cell recruitment, and also starts talking to the adaptive immune system. So this is now what is happening here. Can you see my arrow? There we go. So the plasmacytoid dendritic cell, which is over here, is seeing a lot of these nets and other types of apoptotic material, which is not being cleared. In the orange here are the various abnormalities, genetic abnormalities that cause these problems. The plasmacytoid dendritic cell then becomes activated, releases a lot of type 1 interferon, also starts releasing back, which we'll hear about today, starts stimulating T cells. There is T cell and B cell crosstalk, and you then start getting B cell proliferation. In green, here are all the genetic problems that lead to an aberrant response from the plasmacytoid dendritic cell. In the blue here, all the genetic problems that happen in the adaptive immune response. So there's multiple problems at multiple places that eventually leads to precipitation of a lupus crisis. So the lambda S of lupus is like type 1 diabetes, and this is what is known in genetics as a threshold liability disease, that you need to accumulate a bunch of problems before the disease breaks through. Now, where do antibodies come from? This I'm going to talk about in a little bit of detail, because this is going to come back again and again and again in all of these autoimmune disorders, all of these glomerulonephritis that we're talking about. So B cells are produced in the bone marrow. So the hematopoietic stem cells generate immature B cells, and all the autoreactive B cell clones are taken out through the central tolerance mechanisms. Then the naive B cells are released from the bone marrow, and they go into the secondary lymphoid organs, spleen and lymph nodes, and over there they sit in the marginal zone, trying to scout out their surroundings. If they see cognate antigen in the context of an antigen-presenting cell, then they can undergo two different fates. They can have what is known as a marginal zone reaction, where they proliferate, generate short-lived plasma cells, and give out a burst of antibody. These cells actually die in about 2 or 3 weeks, so they don't live long. On the other hand, follicular B cells, if they talk to what is known as T follicular help cells, so CD4 cells, the helper T cells, can run different programs. If they run the BCL6 program, they turn into what is known as T follicular help cells. T follicular help cells live at in the lymph nodes, and when they see cognate antigen, they can stimulate follicular B cells, and this help is cardinal in activating the B cells, which can then have different fates. So now let's take a look at it. Look at this here. This is in a secondary lymphoid organ, so spleen or lymph node. This is the outer gray zone of the germinal center. You've got a dendritic cell. This would be a plasmacytoid dendritic cell, which actually is going to present antigen to the naive B cell. Now, this naive B cell will then talk to a T follicular help cell, which is running the BCL6 program, and is going to provide co-stimulatory help to this B cell. Now, this B cell will start undergoing proliferation. This is your germinal cell reaction, and this has multiple fates. One of them is generation of the germinal central B cell. We're not going to talk about the other things. This then leads to the phase 2 of the germinal cell reaction, and in the dark zone you see a bunch of these germinal center B cells proliferating. Again, you get help, and now they can actually develop into either memory B cells, which can then circulate, scout, and if they see this antigen again, they can immediately turn into plasma cells and give sheets of antibody very, very quickly. Or they can turn into long-lived plasma cells. Long-lived plasma cells typically migrate back to the bone marrow. They live in the bone marrow niche. They are CD19 negative, CD38 positive, CD138 positive cells. So that's their phenotype. And these can stay in the bone marrow niche for decades. So when we vaccinate somebody against, for instance, mumps or measles, they have these long-lived plasma cells that sit in the bone marrow niche and can chug out antibody for 10, 20, 30 years. But these guys just do that. They can just chug out antibody. They can't see antigen directly. The guys that see antigen directly are the memory B cells. As soon as they see new antigen, this is there in the background. This is the second wall of protection. You have this burst of antibody coming out. So in lupus, I would like, before we go on to the details, to point out there's two other things that we need to learn about very, very quickly, because you'll be seeing a therapeutic intervention talked about in this milieu. So this is your bone marrow. You've got the immature B cell. It converts into, it kills out all the autoreactive B cell clones, and it sends the naive B cells into the spleen, where once they start activating themselves under the effect of these two cytokines, BAFF and APRIL. BAFF is B cell activating factor, which is also known as blessed B cell B lymphocyte stimulator. And APRIL, these are TNF type cytokines, TNF family cytokines that have a cardinal role in the development of B cell as the B cells are undergoing the marginal zone or follicular reactions that we talked about. Once the B cells have this follicular response, it migrates into the germinal center in the secondary lymphoid organs, and it then starts developing into plasma cells and memory B cells. And all of this is very dependent on BAFF and APRIL. And this is why over the past 20 years, we have tried really, really hard to see why can't we treat lupus by depleting B cells, and this is where the idea of rituximab came out, or why can't we block some of these cytokines and interrupt the lupus process? And this is where belimumab comes in, which is a blocker of BAFF. So we'll talk about some of that, but this is kind of where these ideas come from. Now, whatever be the issue, you start making these autoantibodies, and these autoantibodies are actually detectable for several years before either manifestations of lupus or the diagnosis is made. So there's a variable amount of time before you get that. So sometimes you'll get these guys here completely asymptomatic, no problem, but the AMA and dsDNA is positive. You scratch your head and you kind of say, okay, let's see what happens. But after 3 years, after 4 years, sometimes these markers turn positive. The first case of Antiphospholipid Syndrome that I diagnosed was in Pakistan, actually. And this was a young girl with VTE, which was considered idiopathic at the time. And 2 years after the diagnosis, her lupus markers turned positive. There's, some problems with immune immunity to develop illness. This is where genetic factors kind of pushing you into that. Remember the threshold liability, and then certain environmental and hormonal factors obviously affect this, evidenced by the fact that there's a 10-to-1 female to male preponderance of the disease. So this is, the first figure that I show you. This is a long drawn process. We can intervene in this process in several areas, but generally we start doing this when this process has been going on for decades. And this leads to sometimes a very choppy response to very elegant interventions that we think should make sense on the drawing board. So now when this has been going on for a long period of time, we need to start focusing on lupus nephritis itself. When this has been going on for a long period of time, sometimes antigen and antibody complex. Remember, I told you that there's nets which are in the circulation. When you have these antibodies against nets, you can make the antigen and antibody complex in the circulation, and that antigen antibody complex can actually deposit in multiple capillary beds, and the glomerulus is one of them. Sometimes you have antibody deposition and in situ immune complex formation. We will have a little word about exostosin 1 and exostosin 2 antigens in lupus nephritis, and that's a very good example of that. Now, these antibodies have to deposit in the mesangium first. So they're in the circulation, they seep out, go into the mesangium, and that's where they initiate deposition, and that's why mesangial deposits are very important for lupus, and then they can get into other areas. So this cartoon shows the different types of lupus. So let me just explain what this cartoon is showing. You've got a glomerular capillary. The yellow thing here is the endothelial cell. This is the fenestrated endothelial barrier. You've got the glomerular basement membrane. The guy in the green is the epithelial cell. You've got these podocytes here, epithelial cell body. The red is the mesangial cell. And what you're seeing here in black is some deposits in the mesangium. All you see is just a little bit of deposition in the mesangium, and this is how you define class 1 lupus. The histopathology on light is going to be completely normal. You are going to see immunofluorescence in a mesangial pattern, and you will not see any proliferation in the mesangium in class 1. In class 2, the difference now is same thing, nothing inside the capillary loop, nothing outside the capillary loop, but the mesangium looks like a surface here. There's mesangial cell proliferation. And I'll just make a point which Dr. Latif may want to elaborate as well. There's a little bit of a misnomer when we say proliferative GN. So the mesangial proliferation is a true proliferation. When we say capillary proliferation or endocapillary proliferation, what that really means is there's an inflammatory infiltrate here. It's not that the capillary cells are dividing in any way. So now in class 2, what you're going to see is mesangial proliferation, multiple mesangial cells, a lot of deposits. So this will look like on light with some mesangial expansion and proliferative changes. Immunofluorescence, you will see the same mesangial pattern of immunofluorescence activity. And on electron microscopy, you will see a bunch of mesangial deposits. The situation changes in class 3 and class 4 lupus. Now you've got the endocapillary proliferation. And see what we mean by endocapillary proliferation is now you are going to see deposits in the subendothelial space, because now the antigen and antibody is seeping through here, and you are actually seeing a recruitment of inflammatory cells because these antigen and antibody deposits are fixing complement and inviting the inflammatory cells to come in. And you will see infiltration of some of these inflammatory cells into the mesangium. You'll see mesangial proliferation. And in all cases of lupus, all classes of lupus, you will see mesangial deposits. Now, class 5 is where there's actually no proliferation. You don't see mesangial proliferation. You don't see endocapillary proliferation. All you see is subepithelial deposits, subendothelial deposits, and mesangial deposits. So this is class 5 lupus, pure class 5 lupus, in distinction to class 4 or class 3 along with class 5 lupus, seems to be a benign stratum of disease which has a better prognosis than all the other proliferative entities. And when this thing has been running amok in the kidney for a period of time, you start sclerosing down, and you end up with class 6. I'm sorry, I don't have a class 6 in here, but I made a mistake and probably put in 2 class 3s and 4s here. So this is how we actually proceed in lupus nephritis assessment on histopathology. The question is this lupus? Are we seeing active or sclerotic lesions? If we are, and if more than 50% of glomeruli are involved, then we are looking at class 4 lesions. If we have active and sclerotic lesions and less than 50% of glomeruli are involved, we will call it class 3. But if we don't see active or sclerotic lesions, but we do see membranous lesions, so subepithelial deposits, subendothelial deposits, and mesangial deposits, then we are looking at class 5. On the other hand, if we are not looking at membranous lesions and we are looking at just mesangial hypercellularity, then we are looking at class 2. And if we don't even have mesangial hypercellularity, just mesangial deposits, we're looking at class 1. And a separate animal is what is called lupus photocytopathy, where you have mild mesangial hypercellularity, or so just class 1 or class 2 disease, but you have diffuse foot process effacement. And so that then qualifies as lupus photocytopathy. So I'm going to let Dr. Latif go over some of the histopathology slides, and then we'll switch to cases.
Can you hear me, Irfan Bhai?
You can, yes.
Okay, so this, thank you so much for explaining with all those pictures. It makes my job much easier. So my first slide is a picture of class 1, which is a normal glomerulus on HNE, like HNE slides. And the right side is a immune complex deposits in the mesangium. And when we, these are the fluorescent green ones are the mesangial deposits. And they are usually almost all the time, these deposits are full house, means they are positive for IgA, IgG, IgM, NC3, C1q, kappa, lambda. Most of the time when the patients get a biopsy, they didn't get any treatment first. They do the biopsy first to make the diagnosis, and then they start treating. But sometimes they do biopsy after the treatment to see the response. In those situations, the full house staining is not there. But then we have to have a clinical history, correlate with the serologies before I can call it lupus. And this is the EM picture of class 1. You can see the capillary loops are there, the podocytes are there, and then in the mesangium, those dark densities are the small deposits in the mesangium. And when we see this and we correlate this with IF, then we call it class 1. Class 1 and class 2 are very uncommon in my practice because I think clinically they don't give much symptoms. That's why by the time you guys order a biopsy, it's either 3, 4, 5, or a mixture of 3 and 5 or 4 and 5. So this is number class 1. Next slide is class 2, where you can see increased mesangial cellularity. So it's kind of a mesangial proliferation there. We call it mesangioproliferative lupus. And by the way, these classification are ISN RPS classification, which is the most recent one. There are multiple WHO classifications, but we don't follow those old ones. So I'm talking about this new classification. Here the deposits are a little bit more, but they are still in the mesangium, and they are not involving the capillary loops or subendothelial location. And that's why this is class 2 lupus. Same, clinically, the patient may have some proteinuria, but not much. And on EM, this is like you can see the center area where there are deposits, and it's some mesangial deposits, but they are much more in quantity wise, they are much more as compared to class 1. So I
Just quickly butt in, Shamila, just for a second. So there's a lot of nephrologists like myself who have a lot of difficulty in reading electron micrographs, and it just looks like a bunch of quibbly lines. So, the way I orient myself is to find a basement membrane. So you find a basement membrane here, and then, here we're happy that there's a red blood cell here, so you know that this is the inside of the capillary. And on the outside, you can see this podocyte here, and these are the podocyte foot processes. So Shanila, can you just quickly walk us through on how you orient yourself on these EMs and how you look at them?
exactly a similar way. Like these are, to me, they are flowers, and they have these shapes of petals, and those basement membrane is my one petal, and dark red blood cells always, in the lumen you see the dark red blood cells. So that these dark black are the red blood cells, and that's how I see, okay, the endothelial space is there. And then they usually connect by mesengium. So the center of the glomerulus right there is your mesangial area. Most of the time the deposits are along in the mesangium, but along the basement membrane. If you follow the basement membrane, all those dark, right there, those are all mesangial deposits. As well as on the other side where you were pointing towards the base of this picture, Irfan bhai, bilkul niche, right there, those are the deposits, exactly. So that's how we orient endocapillary, extra outside the capillary. The basement membranes are the limiting plates there, right? So if it's outside the capillary loops, then it's epimembranous deposits. If it's inside the capillary loops, then they are subendothelial deposits. And if they are in the mesangium, they are mesangial deposits. So yeah, it's very simple. Okay, so this is class 3. So class 3, when, as you said, Irfan bhai, when the capillary loops are involved in class 3, and this is on my, like, 3 to 4 o'clock direction, you can, yeah, right there is a segmental necrosis of this glomerulus. And you can see the fragmented red blood cells there, some neutrophils there, damage in the capillary loops. And this is kind of an early lesion. After this lesion, you start seeing crescents or class 4. So okay, so the difference between 3 and 4 is very easy. You count all the glomeruli. If 50% or less are involved, we call it 3. If 50% or more are involved, we call it class 4. So this is an example of class 4. You can see a lot of glomeruli. They are very hypercellular. They have this kind of a lobular accentuation. Maybe you heard that word. Simply means that they are, you cannot see any capillary loops there. They are all gone. So the capillary loops appears that they are gone, and the lot of mesangial proliferation as well as inflammatory cells there. That's why this is kind of an endocapillary. We use the word endocapillary proliferation still because that's how it looks like. This is a one feature, one histologic appearance of class 4. And then the second one, the right-hand side one, yeah, right there, you can see wire loop-like lesions right there. Exactly. These dark pink areas are wire loop-like lesions. Simply these lesions means that there are lots of subendothelial deposits there. When you have a big, huge deposits in that location, then you started seeing wire loop-like lesions, and you see most of the time these lesions are in class 4, but sometimes, occasionally, you can see 1 or 2 glomeruli with these lesions in class 3 also. So yeah, so this is a class 4 of lupus. And then also, okay, so all these things count as active lesion. Whenever I see a biopsy, I always try to comment activity index and chronicity index. So we count endocapillary proliferation as active lesions, Wire loop-like lesions are active lesions, crescents are active, neutrophils are active, necrosis of the capillary loops are active lesions. So it's to give you guys a best idea how active is the disease in the kidney. Those are the things I try to put in my report. So this is class 4, and next slide would be the, yeah, some more wire loop-like lesions you can see right there, and then those hyaline thrombi-like stuff, yeah, right there. They look like thrombi, but they are actually not fibrin thrombi. They are usually, most of the time, big, huge electron-dense deposits. The way you can tell the difference between if they are fibrin thrombi or the deposits is a silver stain and the trichrome stain. This is a trichrome stain. This is easy to tell because the deposits are usually red on trichrome stain right there, and they are along the capillary loops, as compared to the basement membranes, which are more bluish or blackish here, and the stain is not absorbed by the deposit. So deposits usually look red, not the blue. And then the next picture is this is a silver stain. So the silver stain, it's a good picture because it shows you both the endocapillary proliferation. In the middle, you can see duplicated basement membranes right there, exactly. So they are like duplicated, and they have lots of increased cellularity, so you cannot see any capillary lumen there. And on your left hand side, those are the, right there are the big huge deposits, and they are wire loop like lesion right there. So on silver stain, they also look like red deposits, and you can see it easily where the basement membrane is, where the deposits are, because basement membranes are all black and the deposits are red. So the next is the EM of class 4. You can see, yeah, right there, the basement membranes and podocytes are right there. You can follow, these are subendothelial electron dense deposits right there. And the endothelial cell is right there in the middle of the capillary loop. There's a huge cell, you can see the nucleus there. Yeah, right there. So this is an endothelial cell, and then these deposits are along the subendothelial space. That's why they are huge subendothelial deposits. And in the if you come towards the right hand side, there's mesangial deposits too. So in lupus, always, as Irfan Bhai said, you always see mesangial deposits in all kinds of, all categories of lupus, you see mesangial, but to differentiate between different 3, 4, and 5, you have to see deposits along the subendothelial and along the epimembranous location. So this is 4, and then the next one should be class 5. Yeah, so the class 5 is basically a membranous. You put this picture anywhere, I call it membranous unless I have a clinical history of lupus. So the capillary loops are very thickened here. They are diffusely thickened. And you can see there is some increased mesangial cellularity in some of these right there. There is some increased mesangial proliferation there. But the rest of the capillary loops won't show you much mesangial proliferation, maybe 1 or 2 extra cells there. But the way you can see it's membranous, on silver stain, they give you typical spikes. We call it spikes because the stain is missing where there are deposits. So that's why we call it membranous lupus nephritis, because they give you spikes. And also you can see this is the EM of a membranous. The arrows are pointing subepithelial deposits right there, and the other arrow is also subepithelial deposits. They are very close to the podocyte as compared to the basement membrane, which is underneath those deposits. And then if you go towards the right side of this picture, you see the deposits are incorporated in the basement membrane, which is a stage 3 of membranous. So stage 1, stage 3, and then some are basically disappearing. So stage 4 membranous. So these are different stages of membranous deposits. So I thought it's a good example to see how these deposits look like in membranous. So they involve the basement membranes, could be above the basement membranes, could be inside the basement membranes, or could be disappearing. And there's a I've missed the stage 2, which is like spike-like, the very early reaction of the basement membrane, which gives you a spike appearance on silver stain, which is hard to see in this picture because this is not showing the spikes here. And then the next one, okay, so I want to touch a little bit about the blood vessels, because since the lupus involved glomeruli, lupus also involved interstitium and also involved the blood vessels in the kidney. There are actually 3 different pictures in blood vessels. This is a lupus vasculopathy, where you see the deposits in the blood vessels, but you don't see much reaction, like there is no inflammatory cells. So we don't call this as a lupus vasculitis if you don't see neutrophils or lymphocytes or true necrosis of the blood vessels. We just call this lupus vasculopathy. This has a worse prognosis. This is a second example, which is a true vasculitis. In this picture, you can see the inflammatory cells involved, like causing the necrosis of the blood vessel, like this areas. Yeah, right there you can see lymphocytes and neutrophils that are basically causing the necrotizing vasculitis. They do have sometimes deposits there, but the inflammatory cells causes a lot of necrosis of the vessel wall. So this should be treated as like microscopic polyangiitis, like ANCA disease, because this is has the worst prognosis. If the patient has true vasculitis on biopsy, then these patients usually don't do good, and the response to the treatment is also not very good. So I have to mention this in my report. And then there's another entity we discussed. Yeah, this is like antiphospholipid syndrome, where you see lupus anticoagulants can give you thrombi in the blood vessels. And this is all fibrin thrombi in the medium size blood vessels, and those slit-like spaces in the middle right there, those are recanalization of these thrombi. Means it was completely occluded, but now to establish the blood flow, they are trying to make some spaces in the lumen of these blood vessels. So yeah, this is also not very good prognosis wise. This gave you like a TMA picture, like a thrombotic microangiopathy in the kidney. I guess this is my, one more thing I wanna just discuss, like in lupus, 3 and 5 can happen, 3 and 4 can happen. And the last one is like class 6, which is basically end stage kidney. In class 6, more than 90% of the glomeruli should be globally sclerosed, and severe interstitial fibrosis and severe vascular disease. So class 5 is basically, we use a word kaput. Kaput means finish. So after that, there's no treatment. Yeah, that's it. Any questions? I'm here. I'll be happy to answer.
Thank you very much, Shanina. That was very comprehensive. So now that we are armed with the pathology, the pathogenesis and pathology of the disease, we are ready to start thinking about treatment. The paradigm of management for lupus has not changed in almost 50 years. We still tend to split the treatment into 2 phases: induction Obviously, we now know why induction is important. There's an overwhelming immune response ongoing. And so what we need to do is to shut that response down. And so traditionally, induction is the phase that is pretty heavy on immunosuppression. We've used various different agents. Steroids were introduced as induction treatment in the 1960s. And then soon thereafter, people experimented with cyclophosphamide. The famous NIH study of cyclophosphamide in lupus came out in 1986, from which the NIH protocol for treating aggressive lupus came out, although that protocol was not really very hooked to the study protocol itself, but that's how it is known now. And then in 2002, from Taiwan came out studies on MMF, and MMF has been shown to be very effective. And now we've got some other agents as well, but whichever way we want to treat lupus, the induction phase includes a combination of some of these medicines. And then once we've gotten the disease under control, we kind of take our step off the accelerator, foot off the accelerator a little bit, and put them on maintenance therapy. And the commonest agents that we use for maintenance are MMF and azathioprine. Now, what I'm going to do now is to start going into some of these cases. The first case we're going to talk about is a case that Dr. Lainwala submitted, which is a very interesting case, and he has some very interesting discussion points on that. So, Dr. Lainwala, how do you want me to do this? Do you want me to run your slides, or you want to share your own screen? Very good. Dr. Lainwala, we can't hear you. Are you still muted?
Yes, let me unmute him. He's muted. Dr. Linwala, you are muted, so unmute yourself.
Got it.
All right, very good. We can
All
hear
right. So
you. May want to go into presentation mode again, sir.
okay, so this is the case of a child who we are still managing this child. She's a 12-year-old girl who came to us with a 2-week history of low-grade fever, joint pains. She had a photosensitive rash, especially in the exposed areas, mild to moderate swelling, and had hypertension. As per pediatric definitions, this was more than her 95th percentile, and generalized edema. 2-week history, and with all these symptoms, we were quite sure that we're dealing with some kind of autoimmune disease here. And with the symptoms, she was, we were thinking about lupus nephritis. So her initial workup luckily showed normal renal functions, a low albumin of 2.5 grams. In her urine, she had an active sediment and plus 2 proteins. Serum complement levels were normal in C3, C4 was slightly low. ANA was strongly positive, but double-stranded DNA was negative. So given the her symptoms, we did a whole profile of ENA, and the RNP and anti-Smith antibodies, they were positive. So we went ahead and did a kidney biopsy on her. So Dr. Mubarak, may I request you to take over from here, the biopsy?
Can you hear me?
Yes,
Yes,
you
we
can.
can hear.
Can all hear me?
Yes.
Yes, Dr. Mubarak.
Okay. Okay, this is very low power scanner view taken by a special technique. This shows the whole biopsy material that is available for examination in this case. Although the image is not clear, but you can see that it is a very long core, good length core comprising of both cortex, medulla, and the corticomedullary junction is roughly at the middle of the core. Next, please. This is again low power view. This is HNE stain. This is the basic stain which is done on all biopsies, including renal biopsies. From the point of view of diagnosis of glomerular disease, this is useless stain. But I am showing this slide here to highlight just one point. As you can see, the parenchyma is quite clean. There's no interstitial inflammation, and there's no significant component of ATN. And large number of glomeruli can be seen in this part of the cortex. Next, please. This is silver stain. This is very nice special stain to diagnose various glomerular disease, renal pathology. This is again lower half of cortical core, where you can see 8 or more glomeruli. And these glomeruli, although this is very low power, but you can see the glomeruli do not look very much abnormal. The Bowman's spaces are patent, the capillary lumina are patent. There's not much increased cellularity in the glomeruli. And the parenchyma is very well preserved. There's no interstitial inflammation. The tubules are back to back. So there's no active inflammation, at least in this part of the cortex. Next, please. This is the remaining half of the cortex with corticomedullary junction at the top. As you can see, 3 glomeruli in the lower part of the field, they look, apparently they look normal at this magnification. They are not much abnormal, but the gloom at corticomedullary junction near a blood vessel, that looks a little bit different. We will see with a high power in a while. Next, please. This is one of the representative glomeruli. Of course, majority of glomeruli look like this. So this is PS stain. Here you can see very mild, subtle increase in mesangial cellularity and in the left half of the globe, while the right half of the globe is normocellular. One additional thing in this region in this globe, if you concentrate on the capillary walls, they are short, they have rounded contour, and they appear a little bit thickened. So next, please. This is again silver stain, high power view. Here you can see, appreciate that the glomerular capillary walls are short, they are round, they have rounded contours, and the podocytes are also more prominent. They become prominent in all proteinuria conditions. They are a little bit more prominent, and the capillary walls are thickened, and they have fuzzy outer aspect, has got fuzzy appearance. Let us see at very high magnification. Next, please. Next, please. This is this oil immersion view, very high magnification view of the globe. Sorry. Can you go back? Okay, so this, yeah. So this here you can appreciate the spikes very well. These are actually projections of basement membrane material in between the deposits. Deposits do not take up silver stain, but the basement membrane material stains black with silver stain. So spikes are basically basement membrane material. This is the reaction of basement membrane deposits. Okay, so this is of course membranous gene. Next, please. This gloom, which was lying at the corticomedullary junction, is a little bit different from others. Of course, it also shows the changes of membranous gene, but there is an additional lesion in the Bowman's space. You can see at the upper part of the opposite the vascular core, you can see a lesion in the extracapillary space. Next, please. Next. And there is also some interstitial information. This is silver stain, again showing the same region. This is, in fact, in the extracapillary space or Bowman's space. This is again high power view showing the uh, proliferation or hypocellularity in the extracapillary space. This is a fibrocellular descent. As you can see, there's a lot of pink fibrillar material in the background. That is fibrous tissue. And there are also scattered a few cells. So this is basically fibrocellular descent. So there were, in fact, there were 12 glomeruli, of which this one only showed extracapillary hypercellularity in the form of fibrocellular crescent. This one glomerulum showed active lesion. Rest of the glomeruli showed membranous pattern. So, and on immunofluorescence, there was full house positivity. The deposits were mainly in the capillary walls, but there were some also mesangial deposits. So it was, to conclude, this biopsy was adequate. It showed features of lupus nephritis class 5 plus 3 because only one of the 12 glomeruli was involved in this case. And this was active lesion. This was a fibrocellular descent. So we classified it as lupus, combined lupus class 5 plus 3. And the activity score was only 3 out of 24. And cross T score was also very minimal, 1 over 12 or at most 2 over 12. So this was the pathologic diagnosis in this case. Thank you.
Thank you, Dr. Mubarak. So,
Over
like
to
you see,
Dr. Ali.
yes, thank you, Dr. Mubarak. So, like you've seen that this child, 12-year-old, who has symptoms of nephrotic syndrome, very low albumin, and has active lesions. So we managed her by giving her some pulse doses of methylprednisolone, and then maintained her with a high dose of prednisolone. We also gave her, looking at those crescents, we gave her cyclophosphamide 1 pulse. And then we wanted to see the result, and we said we'll see you back in a month's time. So after 1 month, when she came back, her renal functions were still preserved. Her albumin was still low, but slightly better than before, with same proteinuria, but this time negative RBCs. So the sediment had settled. Her albuminuria, her hyperalbuminemia was improving, and renal functions were preserved. So the reason why we brought this case for this discussion is that we're still not sure. Firstly, if the dsDNA is negative, you've just seen the whole pathophysiology of lupus. So if the main antigen of dsDNA is not there, is there an entity that we call seronegative lupus? And in those cases, the other antigens like exostosin 1 and 2, could they be the inciting antigens for this disease? And if yes, if if a patient presents without dsDNA antigen antibodies, then how aggressive should we be to treat this disease? Especially given that her renal functions are preserved, her activity index is not so high, and then which parameters should we use to monitor the response of treatment? If you see there's a non-nephrotic range proteinuria is only thing that is left there, we're not sure what other parameters should we be monitoring in this patient. And then, of course, how should the maintenance immune suppression go on for this child, especially given her age? And then if the activity with just 1 pulse dose of cyclophosphamide has improved, should we continue giving her heavy immune suppression, monthly pulses or not? And maintenance doses also would just MMF and or azathioprine. So I think these are the points to be.
Linwala, can I ask a couple of questions before we launch into this discussion? The first
Sure.
question is, what was the protein creatinine ratio? How much proteinuria did she have? I saw 2+ on the UA. Or was it quantified at all? Do you know? Do you have that information?
Yes. Yes, the protein creatinine ratio was around 1.2. That's equivalent of about a gram of protein in a day.
And the second question I had was, I'm sure it was in there, but I missed it. What were the complements like?
Her C3 was normal and C4 was 0.04. I can.
0.04 is low, high, because I'm.
It's slightly low.
Slightly. Okay, very good. All right. So, and this is a fascinating conversation point for lupus, which points towards several different questions. So let's. I think philosophically, there's two different strands in this discussion. The first strand is, what do the different antibodies mean in the diagnosis of lupus, and can we prognosticate based on the presence or absence of an antibody? Is there a carte blanche that one antibody gets, that, you know, we've got dsDNA that is negative? Is that a strong enough evidence to question the diagnosis or question the strength of the diagnosis? So what do people think? Umar, what do you think about this conundrum? This is a patient who has otherwise very well described lupus nephritis class 3 and 5. She doesn't have nephrotic range proteinuria, although when I look at the albumin level, I question the 1.2 grams. Maybe there may be more urine, and in that snapshot that we got, it wasn't that much. But be that as it may, the biopsy is very, very suggestive. So what are your views and thoughts on the different types of antibodies?
So thank you, Dr. Aga. So we have seen, you know, antibody negative, which is, so if the dsDNA is negative, it could be from other antibodies. For example, drug-induced is seen with the antihistone, and I have seen dsDNA negative in those cases. I think anti-Smith also is helpful. And again, I think what was the ANA titers? You know, ANA was positive.
It was defined as high. So we'll just assume that it was high positive ANA.
So I mean, I think we have seen, so again, the lupus, if you look at the original classification for lupus itself, it's not just one symptom or sign or one antibody or one type of presentation. This could be a multi-system, and a lot of time, even within, when there is single organ involvement, like kidney alone, we have seen, I think, extremes of spectrum from a lot of antibodies. And I think I have a patient who even have ANCA antibodies positive, and I've seen patients who don't have all the classic patterns. So I think, and also the other thing I've noticed, like where in the disease phase you're catching this patient. What if you do a biopsy, say, let this condition kind of go another few months and do another biopsy, and just imagine that fibrocellular crescent would have caused more inflammation and damage, and it would be prolific. So I think with the constellation of clinical presentation, with your very classic biopsy findings, which may not be, I mean, if this was like pauciimmune, then I would think of something else. I think this is going towards the diagnosis of lupus clinically, as well as on the histopathology. Yes, your antibody, that most specific antibody, is kind of not there, but I would still think that your diagnosis and direction of diagnosis is accurate.
I totally agree, 100%. I think that's very, very precise. So, you know, I always look at pathology, as you probably know by now. So essentially, what is happening here is that we are generating autoantibodies, and those autoantibodies are then either causing circulating complexes or fixing antigens in situ to make antigen and antibody complexes. That then fixes complement. And that's why lupus and the complement pathway that is fixed is the classic complement pathway. That is why C1q has such a lot of importance in the diagnosis of lupus. When you see C1q being fixed, you know that the classic complement pathway is involved, and you worry about antigen antibody complexes inciting the inflammation. And by the way, it is these antigens, antibodies, and complements that you're seeing as deposits in there. And those antibodies are the ones that your immunofluorescence is picking up. So since these are IgAs and IgGs and IgMs, these are monoclonal antibodies. Multiple clones of B cells are checking out different varieties of antibodies. And one disease is very different from the other disease. They are in the general spectrum of an autoimmune process, fixing various antigens. But as long as I'm seeing this polyclonal activity, I'm seeing complement activation, and I'm seeing a particular pattern on my pathology, I have the diagnosis of an immune complex mediated glomerulonephritis. And when I see an ANA, which is 98% sensitive for lupus, I have my diagnosis. I actually don't need anything else at all. I've got the diagnosis right there. Now, dsDNA has a sensitivity of about 70%. So even in patients who got lupus, dsDNA would be negative in about 30% of patients, which is fine. But if dsDNA is present in high amounts, in high titer, then that tells me that this is more aggressive. So there is a little bit of a prognostic inference that you derive by that, but I wouldn't question the diagnosis necessarily, as you didn't, and you treated it as lupus, of course. Now, the second question is very important, interesting, and it is topical. So this is basically Sanjeev Sethi's mission in Mayo to define as many antigens as he can by carrying out laser microdissection and then histospectrometry on these biopsy specimens. So they have defined, after the identification of PLA2R membranous, they've defined THSD7, and now they've defined exostosin 1 and exostosin 2 associated membranous nephropathy and several others. And so it turns out that if you look at people who are presenting like a membranous related nephrotic syndrome, and you have excluded PLA2R and you've excluded THD7 and the THSD7 and so on and so forth, you can, in a few of those cases, identify these antigens, exostosin 1 and exostosin 2, and these tend to be present in patients who actually have lupus. So this is the only type of antigen that we have identified thus far, which is present not in primary membranous, but in secondary membranous. So I do not know enough about this to see if there's any prognostic difference. I would still treat it as lupus, membranous lupus nephritis, class 5, or would treat it as a class 3/class 4/class 5, depending on how much proliferation there is. But eventually, in times to come, we will learn more about this. So that much about the antibodies and exostosin 1 and exostosin 2. So let's move to the more important and pertinent question of the treatment regimen. So Dr. Aurangzeb, what do you think about the treatment regimen? Would you treat it this way? Would you treat it differently? You agree with this? Don't agree with this? What are your views on this?
First of all, a very nice case. The thing is, there is a conundrum. Serum albumin of 2.5 with a proteinuria of 1.2. I'm not sure it was 24-hour collection, and then she is a child of 12-year-old. The compliance of 24-hour collection, I'm not too sure about that too. But having said that, if the patient is having a membranous nephropathy and there is a podocytopathy which would involve all the podocytes, the proteinuria is usually expected to be a little higher because that was something that was confirmed. Secondarily, creatinine was good. She wasn't overtly nephrotic as to my understanding. And there was a single fibrocellular crescent. So if that fibrocellular crescent wasn't there, the activity score was 0. Correct me if I am wrong. And that's what I want to learn from this session also. In a pure membranous lupus nephritis, the activity score is 0. And what is the utilization of this current activity score in cases like that? And for example, is there a cutoff of activity score and the choice of immunosuppression in different cases? Having said that, that fibrocellular crescent gave activity score of 3 or chronicity of 1 or 2 or maybe. So for a 12-year-old who is having a normal renal function, not too bad in albumin, personally, I don't feel like that cyclophosphamide was the choice. I would give most probably mycophenolate mofetil along with steroids in this case. Reason being, because there should be a discussion on the part of the patient and sterility issues, fertility issues, and all that. So probably MMF is a better choice. And then again, class 5 lupus, and I have a cognitive bias in favor of rituximab. You already know that. So that may be a second option.
Okay, very good. So that's a viewpoint. So I mean, these are all established induction protocols. So the dose of cyclophosphamide, we must point out, was a very low dose that was used. It was a single dose that was given. And at that point in the fog of war, when you see somebody, young child with active disease, you probably want to get on top of that. Also, in a young child, there's also this question, logistics come into play. The question would be, would they be compliant with MMF? Would they be able to afford it and take it every day? So what cyclophosphamide does, you've got them in the hospital, you've given them a steroid bolus, and you can give them a dose of cyclophosphamide. So from a textbook standpoint, Dr. Aurangzeb, you made exactly the right points. Young child, sterility-related issues, not very active disease, and perhaps you can get away with MMF, but when a clinician is treating, they have to look at the entire picture and the entire operational cycle. So perhaps those were some of the thoughts that were in the mind of the treating team, that, are we going to be able to get on top of this? Because sometimes, you have to look at the con side. That a young child who's got active lupus, and you send them on MMF and they come back after 2 or 4 months and they have not taken anything now, and now you've got a bigger problem than you started with. So I think we can argue this from a pure therapeutic standpoint of what the best induction agent is for this child. And then you have to kind of probably think in terms of, okay, which milieu. So if I were treating this child in the US, absolutely I would use MMF. I would not use cyclophosphamide. But even in the US, I have given people cyclophosphamide when I'm worried that they won't be able to afford the MMF, which in the United States, even with insurance, can be very expensive, or if I'm worried that they won't be compliant. So I have given people cyclophosphamide where I knew I'd be able to get away with MMF. Now there's a question on chat, and since you're the vitamin R person, Dr. Aurangzeb, I'm gonna have you feel this again. So there's a question in chat, and I'm trying to read it.
Can I comment on that?
Yeah, please, Abbas, go ahead.
I'm actually, my approach would be a bit different. Even any circumstances, I mean, obviously, I will do my best to avoid this patient cyclophosphamide. Even in Pakistan, I would try my best to get the cell set for this patient MMF. I think a 12-year-old giving a cyclophosphamide, which is not superior to MMF in induction therapy, I'm 100% sure I would not give this patient a cyclophosphamide.
No, I agree with that. And I think if you go from a pure therapeutic standpoint, this patient probably would not want cyclophosphamide. We wouldn't want to treat this lesion with cyclophosphamide at this point. But I'm also trying to highlight some of the other logistic constraints that may have been in place, which the therapeutic team, the treating team, felt at the time when this patient was treated. But your point is entirely well taken. If you ask me, what would you treat this patient with? I would treat them with steroids and mycophenolate. But let's hear from Dr. Aurangzeb about rituximab. So what's the data for rituximab in a situation like this?
Well, data is mixed, as I said. There was an article I think shared a few days ago on this portal that we use for communication, and I think that the data is not really too convincing in favor of rituximab. There are cases that have responded, and then there are cases that have not. At this point in time, we have recently started from 1st of October. We are trying to make a protocol of giving class 5 lupus. All the patients that are going to be diagnosed in the next 1 year, they will be offered rituximab. provided they will be fulfilling the criteria. So I'm, as of now, in the next 10 to 14 days, we are going through the data in order to come up with the right inclusion and the exclusion criteria. So specifically speaking, what I am interested in, I do read about UpToDate and all the data that we get from West. But usually the behavior of the disease and the response to treatment in our population is slightly different. So I am really interested how our population is going to behave in it. So as because we have rituximab in our setup. So for me, when you have a hammer, everything looks like a nail. So that I would have given rituximab, but only with discussion. MMF first as an option and then rituximab. So I was asking a question, Dr. Aga. This activity and the chronicity score, I know this has been an upgrade to the previous classification, but for me, it is more confusing than helpful. So I want your comments on it. How do you use it as a tool?
Yeah, so I think we've got Dr. Latif on the panel. So Dr. Latif, let's hear it from you. How do you use activity and chronicity scores when you're reporting these biopsies?
Irfan bhai, so we have to have, when we call active lesions, I mentioned that you have to see different lesions in the glomeruli, which is neutrophil infiltrate, endocapillary proliferation. They are all graded from 0 to 3, except when you have crescents and necrosis of the capillary loops, then they grade those as 0 to 6, because those two counts at ×2. So any number more than 12 is considered significant. Like something, if I say there are crescents or necrosis, then it will be 6, because those two lesions count as 6. So 6 plus 6, so 12. So if you have those two lesions, then it's 12 and it's significant. But I think for prognosis, the chronicity is more important. They want to know if there is already segmental sclerosis, which this patient has. It's a fibroepithelial crescent, not just the epithelial crescent. So there is some chronicity to this kidney. There is some. And then the interstitial fibrosis is also important. They want you to mention if there is any fibrosis. Then the chronicity index is out of 12. So we count 0 to 3, but there are only scarring, segmental sclerosis, vascular sclerosis. Those are the lesions that you should mention. But I mean, treatment-wise, anything which is 3 or 4, they treat. Membranous, sometimes they do, some nephrologists do treat membranous, but some they just do symptomatic treatment, not very big guns. Like big guns comes when there is 4 and 5 lesions.
Thank you so much. Because I'm a clinician, I want it to be used as a tool. So I was just curious in your experience, because you are mostly related to so many centers and you're reporting it. A class 5 lupus is going to be, pure class 5 lupus is going to be reported as activity of 0. Is that so?
Correct.
Yes,
Because
that is correct.
you see some mesangial proliferation there, then you can count it. But no, yeah, you are right. The membranous doesn't, activity-wise, like active lesion-wise, doesn't count much.
So if that class is considered to be activity score of 0 and still we have to treat it, so how are we going to use it as a clinician, that this and this number, we are going to use cyclophosphamide and then MMF and then rituximab and all that?
No, this patient has a crescent. It's this baby has...
Not about this patient. I know.
Okay.
I'm just thinking of using that activity and a chronicity score as a directive measure in order to what to choose in terms of treatment for any patient.
Let me look this as a clinician. So the benefit of getting an activity score, a chronicity score, and so on and so forth is to semi-quantify your biopsy. But this doesn't take away from your clinical judgment. I look at the clinical score, I look at the activity index and so on and so forth, but that doesn't drive directly my treatment plan, the thing that drives my treatment plan is what is the clinical presentation, what are the clinical markers, what does the biopsy itself look like. These tools, these scores are meant to stratify and streamline biopsy reports across multiple centers. So when somebody says class 4 lupus, that may be something else for Chanila, it may be for Dr. Mubarak. But when you have putting numbers, makes it apples to apples, and you can actually look at it. But in this, I don't think we take home the message that if the score is 7, I'll do MMF. If the score is 10, I'll do cyclophosphamide. You can't look at it that way. These are meant to streamline biopsy reports so that the reporting is more reporting doesn't have fluctuations from one pathologist to another or one center or another.
Standardization.
Standardization, exactly. Thank you. That was what I was looking for.
So would you treat class 3 and class 4 differently
No,
if the activity score is different?
I usually don't end up treating 3 and 4 differently. To me, proliferative lupus is proliferative lupus. If they've got activity, if they've got a biopsy that suggests that, I treat them. Now, the only thing that is different where I may go a little heavy on treatment is if they've got diffuse crescentic disease or if they've got evidence of necrotizing vasculitis, because I feel, and this is my personal opinion, I feel that these are the segments of lupus that may actually have coexisting ANCA-like activity. About 15 to 20% of lupus patients have ANCA, but we don't know of all the ANCAs. And when you see a focal necrotizing vasculitis and crescent formation, that may actually alert you to the possibility that you've got an overlap lupus ANCA situation here. You want to make certain that you're not sitting on a drug that is causing a problem. But these may be, and this would make me very happy, these may be actually the patients who may be good candidates for rituximab. But here is the other question that I think is very pertinent to look at. And before I go on to that, there was an interesting comment by Dr. Tarif here that, and I'm sorry, I can't keep up with the chat. So Abbas, if you wouldn't mind monitoring chat, because I'm single track, so I can either talk or look at the chat. Otherwise, I'll screw up both. So I'll let you do the chat thing. So let me continue with this. On paper, rituximab should have worked like a charm for lupus. We have said this is a B-cell driven disease. You take away the B-cell pool, and eventually the antibody levels should drop down. But all the studies that we have seen on lupus have given very equivocal results. Why do you guys think that is? Why do you think rituximab sort of failed in lupus? Umar, do you have any views on that? Any thoughts on that? What are your ideas? And nobody knows the answer to this. We just have ideas.
Yeah, I don't know the answer to this. I think I remember when I was I think fellow, we presented a meta-analysis of use of rituximab in lupus at ASN, and it got accepted for oral presentation. The issue is it's kind of, we just pulled all, if there's a wrong data or not very, there was selection bias. So the answer to your question, I don't know. I think this is one of those conditions when it has variable results. I was actually looking at an article, and in summary, they say that, rituximab is interesting in lupus nephritis. This is how they concluded the first line. So my answer is it's interesting. You may hit it, you may not hit it. I don't know.
Yeah,
May I?
Dr. Lehmann, please.
Yes. I see a raised hand from Dr. Ejaz. He's also an expert in nephrology. I think he would defend better than me the role of cyclophosphamide that we use. We use it as a first line, and MMF, we know the data is there, but in our setup and in our population, especially you mentioned that the dose that we gave, the issues of sterility and all other bone marrow suppression, with our experience, we know that it is not that concerning. Can we allow Dr. Ijaz to?
Let me ask you this
I mean,
question, because there was a question that came into my mind, and that is, this is a 12-year-old child, and I know nothing about pediatrics. So if I'm giving cyclophosphamide to somebody who's not yet ovulating, and those cells are all dormant, is the impact of cyclophosphamide the same? I mean, does this still have fertility connotations or no? And I don't know the answer to that.
There are studies, long-term studies done on children who have received cyclophosphamide, and as adults, the magic number is a dose of 225 milligram per kilogram cumulative dose. If you have received more than that, then all the problems of sterility and all other long-term side effects of cyclophosphamide are there. Otherwise, less than that, like for nephrotic syndrome, steroid dependency, cyclophosphamide works excellent. And the dose that we use, the cumulative dose, is around 168 to 180 milligrams. So that's way below the toxic dose.
Okay, can I just short comment?
Please.
Sure.
Okay, so I mean, same. I mean, you're absolutely right. There is a little bit of, I won't say controversy, but there is different opinion, which is the best treatment options. But here in our area, at least in the northeast of America, I'm talking about New York, New Jersey, and UPenn in this area. I'm sure Dr. Farooq is not too far from there. There is no advantage of cyclophosphamide is not better than MMF in induction therapy in no condition. Okay, so and obviously because of much less toxicity, there has to be some specific reason. Maybe some people say that a lot of crescents, not just one crescent, maybe superior cyclophosphamide, but otherwise there is no advantage, rather there is disadvantage of starting cyclophosphamide, I mean, as compared to MMF in this patient. So one more thing. Let me have Dr. Professor Noman speak up, and he has a question. Let me allow him to speak. Professor Noman, you want to talk? You have a question? Dr. Noman Tarif, you can talk, you can ask question if you have any. But let me just read his question then. So he's asking that, yeah, fertility issue, we spoke about that in pediatrics and adults. And is MGN and lupus and the primary MGN, same view, them same for the rituximab. If there is no crescent in this case, would you give conservative therapy for next 6 months? So that's his question. So I don't know which is a conservative therapy, which is like aggressive therapy. Both are, in my opinion, are not conservative. Both are aggressive therapy, cyclophosphamide and MMF.
Right. So I think, excuse me. Avas, could you please take over for a second? Just give me a second.
Sure. Again, back to Dr. Aurangzeb about rituximab. I mean, at least if you go by recent evidence, yes, in my opinion, their evidence is not there about rituximab to be in lupus nephritis to be a first-line therapy at this point, in my opinion. Dr. Farooq, what do you think about that?
Well, that's true. There isn't any solid evidence that we should do it as a first-line therapy, even in class 5 lupus. But the thing is that it hasn't been properly tried in our population. And class 5 lupus, it has worked in some situations. And the results are equivocal. So there isn't any biblical statement that I can make that rituximab should be the primary choice in class 5 lupus and so. I wanted to advocate on the part of Dr. Lainwala. The problem in Pakistan is, and this is true for my institution, that MMF is very costly and the people are not able to afford it. So sometimes there is a very critical balance in terms of what to offer, what we want to offer, and what we expect that the patient may be able to take. Cyclophosphamide is something that we can give.
What do you think as a
Next time
therapy?
you'll come, it's going to be free. In
As a
MMF, I was talking about cyclophosphamide versus MMF in terms of induction, because cyclophosphamide was used by Dr. Lenwala. So probably that was one of the reasons, but he has told me the other way around, that they have found it to be not that toxic as we feel it to be. So this is something that is new for me, because as far as in an adult population in Pakistan, the primary reason for losing a patient of cyclophosphamide is not really of renal or a cardiac origin, it's infection. So sometimes when we have to give a cyclophosphamide to the patient, we are very, very skeptical about the infections that we may get.
So I think that's an interesting point. We have to tailor therapy, but I think we'll still have a hard time justifying that cyclophosphamide is perhaps less toxic than MMF. Cyclophosphamide can be toxic, and again, the data for using just one dose, I mean, we have to go by what database we have, what studies have been done, and what seems to work and what doesn't. So lupus is a very chronic disease. It doesn't go away with one round of treatment. It will come back. It will continue to linger. That is why you have to treat these people for a prolonged period of time. So you may actually put the disease into a temporary remission by one jab of treatment, but if we don't follow it up with continued treatment, we are actually setting that patient up for failure, because eventually they will fibrose that kidney off. And if we don't immunosuppress them appropriately, if we don't immunosuppress them with the appropriate strength and the appropriate duration, then we will not have good results based on the cohorts of patients that have formally been studied. So there are different ways of doing cyclophosphamide. As we all know, the original NIH protocol was 0.5 to 1 grams per meter square every 3 months. And then it was kind of switched over to monthly infusions for the first 6 months. And then you go into a maintenance mode. But you treated those patients with cyclophosphamide for 2 years. The Euro-Lupus protocol, which is in a slightly different patient population than the patients that we see in the US, but still the Euro-Lupus protocol is 500 milligrams per meter square, and you give them 6 doses. But then you follow them up with maintenance therapy, and the maintenance therapy targets are the same whether you're using IV cyclophosphamide in the full dose or in a reduced dose. So this is where the burden is. You have to thread that needle where you treat them appropriately based on a regimen that has been ascertained to be effective, yet you have to be careful that you don't have too much of an infection burden. So if there is a thought that you can work on a hybrid regimen where you use some cyclophosphamide, use some MMF, then that really needs to be studied. Otherwise, we can just have a situation where we are treating patients without the requisite response and no way to verify what's working and what's not. So that would be my thinking on that.
Okay, Irfan, let me ask you a question, and Dr. Farooq, because you are in US. So if you have a patient, you have stage class 4 lupus nephritis, and you forget about toxicity or price. So patient is either African American or Hispanic origin. What would you choose, MMF or cyclophosphamide for induction?
MMF every time. MMF
Okay.
every time.
So that is superior to, in that population, that is superior to cyclophosphamide. Okay, and we don't know which category the Pakistani come. I mean, whether they're close to white population or close to African American, close to Hispanic. We don't have study on that.
I always add the white population and the black population and divide it by 2, and that's how I
Exactly.
for Hispanics as well as for Pakistanis.
So Avas, since you asked the question about the practice pattern, I can tell you that at my hospital, so we treat all these lupus patients in conjunction with rheumatology. So anybody even with pure lupus nephritis, and if they're hospitalized, we always take their opinion. And we do have a propensity of use of cyclophosphamide in in a lot of cases, especially disease severity and compliance and side effect profile, I think those are some of the decision factors. So we do have utility. Actually, one of my colleagues, he is a big fan of using rituximab anytime he has a hint that patient, sorry, not rituximab. I keep using the word rituximab by mistake. Using cyclophosphamide anytime if patient has a hint of non-compliance, or because we have seen some of our Hispanic young females in our one of the county where they are either lost to follow-up or they cannot afford or consistently take CellCept. So we have actually used cyclophosphamide for those patients after going through some counseling with our genetics team and with our MFF team, just to make sure that, you know, patient is aware of all these risks. Because we have, for some reason, I think I have seen very severe cases of like life-threatening, not just organ-threatening, life-threatening cases of lupus in our region. So we use cyclophosphamide more so as the induction therapy than CellCept alone. For hospitalized patients who have severe disease, even in younger patient, when there is this risk for, like, you will end up losing them to, you know, follow up.
Well, and that is fine, because that's kind of the situation where I have used cyclophosphamide as well when I'm worried that they won't be able to afford the MMF and something. But we always have to be careful that if you find that there is a patient who's a follow-up risk, right, then you have to balance the risk of infection as well, because if they're not following up with the medicine, they're also not following up with their PJP prophylaxis and their fungal prophylaxis and so on and so forth, and they can actually land into a bigger jam. But your point is very well made. There are patients based on disease severity. So, you know, you've got crescentic disease with pulmonary hemorrhage. A lot of people would give intravenous cyclophosphamide to begin with, and then switch them over to cyclophosphamide to MMF.
One quick question. So if that's what I would do if I don't have MMF choice as a price-wise or otherwise. So cyclophosphamide is a good option in that case, but at the same time, depends on the severity of this patient, which looks like very severe. I mean, other options are like, before I go to tacrolimus, rituximab actually, I would go to cyclosporin or even azathioprine before per evidence at this point.
So let me make a couple of points on cyclosporin and azathioprine, and those are good agents. We're using them more and more, but they are used in conjunction. You can't really treat significant lupus with just steroids and cyclosporin. It has to be a tack-on, and we will talk about a couple of cases. So there's good data on multi-point therapy with cyclosporin, but I don't think there is any significant data that would say you use it as monotherapy or as the sole backbone of therapy in lupus nephritis. Azathioprine as an induction agent is a weak induction agent. Even in the NIH studies, if you look at the breakouts, so they had 107 patients. The two breakouts were cyclophosphamide IV or cyclophosphamide oral, right? Everybody else, the steroid alone, the steroid azathioprine, et cetera, were jumbled down below. So induction-wise, at this point, our main choices almost always are you use steroids, unless you're on a rituximab protocol where you will kind of give the initial steroids, but then not do anything else. But, you know, rituximab again is rituximab based and iffy. So the main choice between induction agents is MMF and cyclophosphamide. And MMF can be used in a resource-rich environment in almost all the cases. It can be used. Now, some people, and it's a style thing, some people, like Umar mentioned, people who are very sick, who are in the ICU, who have pulmonary hemorrhage, who have crescentic disease, some people will still give them cyclophosphamide as induction, and that's fine. That's what they think is the best induction agent at that time. But for the other 98% of the cases or 97% of the cases who've got class 3 or class 4 lupus, maybe a few crescents and so on and so forth, they can be treated with MMF. So your point is entirely well taken. Cyclophosphamide is a more toxic agent, but we've used it for 20 years before MMF came around. And so there is some niche where it can be used. And I'm looking at the situation in Pakistan where you can make a case of using cyclophosphamide if you don't have MMF. If you don't have access to MMF, I would much rather, in a case with significant lupus, use cyclophosphamide for induction than to go on to a third line or a fourth line agent if I can do it safely. So, again, there is very little data for calcineurin inhibitor growth therapy in diffuse proliferative lupus or even class 5 lupus.
May I?
Yes.
We at SIUT we do not have this problem of availability. We do have both available, and it's free of cost to all the patients. We also have Myforte, the enteric coated mycophenolate. But our experience, especially in children, is that MMF has more GI side effects in our population as compared to what we read in the literature, or maybe you people experience in the West. I don't know, is it something racial or something that GI upset even in our transplanted patients with MMF is a very significant problem, and especially when given in a higher doses. So, and again, our experience with cyclophosphamide is it's like, the old time cardiologist still preferring digoxin. I mean, we've used it, we know in and out, we know everything about it, and we have long-term data of it, feel comfortable with it.
But I think you're kind of making Aves's point for him. So, but I mean, to be honest, you have to tailor your therapy with the population that you're treating. You've got rich experience. You see a lot of patients, and if your patients have a hard time tolerating the drug, that's a valid question. If I were operating in that milieu, and if I had the drug available, I would let the patient fail therapy first. So people I can get away with MMF, I would do that. If they fail therapy, then I'd say, okay, he's not tolerating MMF. Now let me see what I can do to salvage the situation. That may be one way to thread the needle here, which will make Avas happy as well. Happy, Avas?
One more point I wanted to ask regarding this calcineurin advocacy. To my understanding of the pathogenesis, as I am a student, you are the professor of pathology, I should say, and I am just a student in it. But the thing is, CNIs, when they work in even in flour positive membranous, usually they are not effective on that flour titer. Whenever they're not that effective. So antibody driven disease, in that kind of disease, usually the relapse rate is quite significant. So where do you rank cyclosporin or tacrolimus in an antibody driven disease like this one?
So the thing is that you have to kind of look at what is generating the antibody. So the reason we are now looking at calcineurin inhibitors as adjuncts is to kind of look at the whole cycle of how the antibodies are produced. Let me see if I can get to one of those slides. I think that will take too long to get that. So I'll just try to describe that. So there is a lot of interest in the germinal center reaction. And what happens in the germinal center reaction is that you look at a cognate antigen. So the antigen presenting cell will pick up an antigen, and then it will present that to a B cell. That turns a naive B cell into a follicular B cell. So this B cell is now beginning to scavenge around for help to see if it can start proliferating. And that help comes to it through a T cell. And so the T follicular helper cells, so these are called TFH cells. These are the cells which are a kindred or subtype of helper T cells, which are running the BCL6 program. So their entire mission in life is to pick up activated B cells, give them T cell mediated help, and allow them to become follicular B cells that can go into the germinal center and start proliferating. So that is a cardinal step where you can use calcineurin inhibitors, which then will stop the activation of T cells and stop the generation of T follicular help cells and cut down this germinal reaction. So this is a totally different, so this is the only T cell mediated therapy that we use for lupus. Every other therapy that we use for lupus is on the B cells, either the anti-proliferative or anti-lymphocyte proliferative therapy. That's all headed towards B cells. Your rituximab is all directed at B cells. Your belimumab is all directed at B cells. But this is the only part of treatment that actually attacks the T cells. And this is why I'm going to just jump straight to transplant. This is the new way of looking at chronic antibody-mediated rejection as well. And this is why we feel drugs like bortezomib fail in chronic antibody-mediated rejection, because as soon as you deplete cells, B cells or plasma cells, there is a fire in the lymph nodes and there's this huge germinal reaction. And if you don't block that germinal reaction, you will have repletion of the antibody producing cells very quickly and your depletion therapy will fail. So coming back to rituximab, the reason I think rituximab has been suspect is that we don't feel that the depth of B cell depletion by rituximab is significant enough. Because we follow it through CD19 counts, and there's ways to actually parse those CD19 counts further. There's some circulating plasma blasts in there and so on and so forth, which with high fidelity flow cytometry, you can parse those little subsets out. And that may be actually more reflective of the state of B cell depletion, but it looks like the newer anti-CD20 antibodies of inotuzumab, etc., may actually be more potent, and we don't know that. This is how they are being marketed at this time. There is no head-to-head that I can tell you, but it sounds like the reason rituximab is not successful in some of these cases is because of maybe a little bit of lack of potency, which circles back to Dr. Tarif's question, which I'm actually looking at the screen now, that this may be the cardinal difference between a PLA2R membranous versus the membranous that you see in lupus, that the pool of antibody producing cells is much more robust and perhaps resistant to or sort of refractory to the way we dose rituximab at this time. And maybe the answer is to use other agents or combination therapy. But again, these studies are being done now. We don't have that data.
Can we quickly go to the next question if we have?
Yeah, please. I think we have, what time is it? It's 1:48. So I think Umar's question, like always, Umar's case, we'll start with that next time. Umar, is that all right? Because if we start now, it'll be another hour. I think
it's actually 2:48. So.
Yeah, so yeah, I mean, I'm in Central Time, so.
Okay, sorry.
Last question, Abbas, and then what we'll do is we'll pick it up on the next side. And then on the next week, what we'll do is we'll start with the Umar's case. We'll kind of dissect it like we did this one. And then we'll have some rapid fire cases where we'll kind of try to decide what would be the best therapy for that clinical scenario. We'll have 5 or 6 of those, and hopefully we'll have good discussion at that time. So let's have the last question then.
Okay, let me ask Dr. Tarif. He's on. Dr. Tarif, you want to talk to, or you have any question, any comments?
I think he said he has mic issues in the chat.
Okay, probably not. Okay. Let me see if any. Let me ask.
Dr. Adil has, he still has a raised hand on the attendees list. I don't know if he still has a question.
Adil, could you unmute yourself, Adil?
I think we have to let him.
I think the administrator has to allow.
Let me see. What's his name? Adil?
Ask him.
First name or last name? Okay.
So Dr. Adil Manzoor Ahmed, he's like very high on the list.
Where's the one? Shall we say?
Oh, okay. Yeah. Dr. Adil Manzoor,
Yes.
you can
Yes.
talk.
Doctor, thank you very much. Just
Sure.
I have a couple of comments. The only advantage of cyclophosphamide as an induction therapy in lupus is that in the maintenance of the remission, if you induce any patient with IV cyclophosphamide and then go to the maintenance regimen of MMF and azathioprine, versus if somebody induces with MMF and then continues as the maintenance regimen of MMF and azathioprine, the chances of this patient to stay in remission will be slightly higher as compared if you have started with an MMF. This is my one point. The number, and this is Irfan by your Brad Robbins data. And number 2 point, my point is that regarding the ineffectiveness of rituximab in lupus, is that the long-lived plasma cells which lie in the niche of the bone marrow, they are not affected, because as you know, this short-lived plasma and long-lived plasma cells in the lupus, it continues to remain active and keep affecting on the antibodies, keep producing the antibodies. The rituximab is an anti-CD20 drug, so it will not have any effect on the plasma cells. That's why few studies are coming, I think 1 or 2 I know, of bortezomib acting on the plasma cells. But they are not N is equal to 12, 11 like this, as far as I remember from the top of my hand. This is a point, and the one point which I wanted to ask from Dr. Shahina, I think she has left. Is the lupus membranous also all these stages, stage 1, 2, 3, 4 are described well? As far as I know, as Umar also has an exceptional knowledge in membranous, that I'm not aware of these stages present in the lupus membranous. They're well described. They do not correlate with the clinical correlation, neither with the one stage will go to the 2, 3 as a, or it will go reverse back. This is my one. And the other ones, Irfan, do lupus podocytopathy have immune complexes?
Yeah, so essentially you will see lupus podocytopathy with a either class 1 or class 2 disease. So essentially what you'll see in cases with lupus podocytopathy is nephrotic syndrome. When you do the biopsy, you'll find that there's mesangial deposits. There's some immunofluorescence activity, but it is barely class 1 or class 2. And when you look at the EM, you see mesangial deposits and you see diffuse leukocytosis. Now, people with lupus can get minimal change disease. So, you know, it's a question because it behaves pretty much like minimal change disease. It melts away pretty quickly with steroids. So the question is this minimal change disease in the milieu of lupus, or is this some of the anti-nuclear antibodies acting as the proverbial permeability factor and causing podocyte injury and proteinuria thereof? But either which way, the construct of lupus podocytopathy is that your lupus should be class 1 or class 2. If it's class 3 or class 4, then you can't call it lupus podocytopathy. Obviously, if it's class 5, you've got membranous disease and you have to.
Another point regarding Dr. Aurangzeb's question is also that he said that to manage the patient in relation to the histology of the case, the patient has to be, patient has to be taken in all the things histologically. Well, the clinical context is if there is a membranous nephropathy and he has a 10 grams of proteinuria and he's a lupus man, then he has to be treated as the induction therapy, or if he has a 5 or 3, even if the histological activity is low. So all the things regarding to this patient, personalized, as Irfan and Masood was very highlight, patient-centric approach should be taken in this regard. The other question, Dr. Ali, regarding the Euro lupus protocol, which was using 500 milligram every 2 weeks for a total of 6 doses. In this child, do you think that 250 milligram every 2 weeks for a 6 doses may be sufficient for him?
Well, I don't know. I don't know the answer, but the cyclophosphamide, when we give it, we usually get the response after a week time. And if there is any bone marrow suppression, that it usually recovers after 2 weeks. So hitting them again after 2 weeks, we were never convinced. So we have actually never followed this 2 weekly protocol. We always give a monthly cycle of cyclophosphamide in whatever disease we use.
Regarding rituximab, Irfan, I want your comments according to the rituxi lupus protocol. You know, Liz Lightstone is a great promoter of less steroids in lupus. She advocates only that you give methylprednisolone only in the first induction and never repeat IV methylprednisolone. If there is a relapse, you just treat him with 0.5 milligram of steroids along with the induction regime, which was used in the first. So she has used rituximab with very, very low dose of steroids and tapering it quickly. And she has used in almost the same protocol as used in the protocol in the Mentor trial. And she has reasonable results regarding the response of rituximab in membranous nephropathy. So what is your thoughts regarding very less steroids, not repeating the methylprednisolone again and again as it is done in Pakistan? Whenever there is a mild arthralgia, the rheumatologist pulse him with methylprednisolone and they end on our doorstep with fungal or bacterial sepsis, and using a rituximab with low dose steroids in a lupus setting.
So I would agree with most of the allegations you made about Liz Lightstone and rituximab, apart from the last one, which is that she had reasonable results. Actually, rituximab did not complete enrollment. They could not randomize enough people, so it did not achieve power. The results were equivocal, so it weren't great results. But you could demonstrate that you could get away with less steroid. This is why there's a lot of interest in Bliss. This lupus nephritis just got published in New England Journal of Medicine a little while ago. This is a very good paper to read and dissect in our journal club exercise, because there's some very interesting issues that happen with this paper. But the big picture bullet point is that people do a little bit better maintaining remission when belimumab is added to people with lupus nephritis on top of standard therapy. And all of these steps are being taken to minimize steroids. But I don't think we can use rituximab as the poster child of how to use rituximab in lupus nephritis. For the most part, that trial should be put in the failure bucket rather than in the success bucket. But
Great.
Your point is well taken, that we get away with steroids, but we will only get away from steroids when we have other drugs which are easy to use and are cheaper to use. I would also make one other point, and that is the focus on long-lived plasma cells. Long-lived plasma cells are actually, there would be some long-lived plasma cell populations in lupus, but the main problem with lupus is repeated recruitment. So there's two ways of having sustained antibody in blood, right? The one is you generate sheet after sheet of long-lived plasma cells, and that happens after a lot of vaccinations. That happens with HLA inoculation. So when you have blood transfusions or you have pregnancy and you see non-self HLA antigens and you generate HLA antibodies. So some of the immune reactions divert your antibody production to long-lived plasma cells. Now these produce sustained levels of antibody for prolonged periods of time. This is why in the transplant world, and you're very familiar with it because you're intimately involved in transplantation, you see sometimes these low-level preformed HLA antibodies. And then as soon as you put the kidney in, you have this skyrocketing response, anamnestic response to the antigen. But the interesting thing is that long-lived plasma cells, like any other plasma cells, they can't see antigen. So they can't respond to antigen. So the thing that actually leads to that blast of antibody-producing cells is a memory B cell response. You've got circulating and lymph node memory B cells that are scouring for those antigens. As soon as they see those antigens, they go into overdrive. And so, like I said, one way of maintaining low-level antibody is through long-lived plasma cells. But another way of maintaining low-level antibody is constant exposure to antigen. And so that's what happens more importantly in lupus, because with ultraviolet ray exposure, other tissue exposures, you have these genetic defects which can't take away the DNA from, or necrotic material or DNA material from the circulation, leading to constant exposure to memory B cells and leading to constant levels of antibody in the blood. And therefore, yes, there are case reports of using proteasome-based therapy in refractory lupus. But the thinking over there is that maybe this plasma cell, memory B cells are making so much of plasma cells, which are generating so many antibodies, that if we kill those plasma cells, we may be able to get on top of the process. But in that case too, we have to cut down the recruitment issue, because the recruitment issue in lupus is crucial. You've got constant recruitment of antigen, and you have to numb the immune system down so that eventually you generate enough regulatory T cells to shut the immune processing down. So that's kind of my take on the plasma cell angle.
Thank you, Jazakallah. Thank you.
I think we're again at 2 hours, and despite my best efforts, we can't seem to cut it off at 1 hour. So I'm very sorry with for all the colleagues in Pakistan, because you guys are, it's going to be close to midnight for you. So I appreciate you guys being there. And I think we'll pick this up next week and we'll have more discussion. I think this was thoroughly enjoyable and very illuminating. We were able to dissect a lot of the therapeutics involved in lupus nephritis in the induction. And I think interestingly, next time we'll have more cases where we have issues later on. Once you've given the induction, what happens next? Because that's where more interesting things happen sometimes, and things with which we have much less data to go on. So I think we'll have a more lively discussion next week also. So till that time, I'll say thank you to everybody.
Let me have some few final words. I think that was great that we spent 2 hours and we went over pathology and histology very nicely. So we refresh our knowledge, and we'll maybe read a bit more in the next few days. But next week, when we do the question, I think we should go quickly over, a short discussion over the cases, so we can go over more cases. I think we have, I don't know how many cases we have, but I think we should go like Dr. Khalil, he just want to put, or add one more case. So hopefully we'll go over cases quickly based on our, refreshed knowledge on the pathology and histology of lupus nephritis.
Very good. Thank you, everybody. Allah Hafiz.
Thank you. Allah Hafiz.
Allah Hafiz.
Thank you.